Hi, welcome to the Journal Pearls, Understanding Upper versus Lower Lung Predominant Diseases. At the end of this talk, we will be able to go back to these three images and choose which is the least likely differential. If you want, you can pause it at this point to answer on your own. A helpful way to remember the upper versus the lower lung predominant diseases is to recall our basic physiology. We inspire and the air distends the alveoli and they would look like this accordion. When we expire, the air goes out and the accordion folds. What keeps the alveoli from collapsing and what keeps it from bursting when we inspire is a balance between the alveolar space and the connective tissue. Let's look at this microscopic level. So gas exchange happens at this point when the capillary endothelium contacts the alveolar epithelium. The spacing between them is called the interstitium. Note that in this interstitium, we have the elastin and the collagen fibers, which form the supporting framework for the lung. Lymphatic vessels also travel in this connective tissue framework. Now, looking at the secondary pulmonary lobule, we can trace the blood flow. So, starting from the lung, you have your deoxygenated blood from the heart and reaches the pulmonary arteriole. Note that the arteriole travels with the bronchi. That's why it's called the bronchovascular bundle. Now, the deoxygenated blood travels here, gets oxygenated, and then the oxygenated blood would then travel in the periphery of the secondary pulmonary lobules because it is the location of the pulmonary veins. Then the blood will go here and go back to the heart to be pumped to the circulation. Now let's talk about ventilation and perfusion. When you say ventilation, it is air exchange within the alveoli. And when you say perfusion, it's blood reaching the capillaries. Because of gravity and differences in oxygen tension and other factors, we can say that the lower lobes are relatively overperfused. Lower lobes are relatively overperfused with this ventilation-perfusion ratio, while the upper lobes are relatively overventilated with this ventilation-perfusion ratio. In addition, there are also other factors like this one. You have decreased lymphatic clearance in the upper lung zones because what drives lymphatic clearance is excursion of the ribs and the diaphragm, which is less at the top compared to the bottom. In addition, lymphatic clearance is also driven by perfusion, which is relatively less on top compared to the bottom. Now, given these two factors, we can now predict the pattern of changes for those etiologies which would present with upper lung predominance. For example, inhalational diseases such as pathologies due to smoking, such as centrilobular emphysema or Langerhans cell histiocytosis, or inhalation of foreign bodies such as in silicosis, goes to the upper lungs. In addition, when you inhale antigens, for example, antigens in farmer's lung or inhaled Aspergillus fumigatus, you will also have upper lung predominance. Granulomatous diseases such as the classic TB also likes the upper lobes because of its higher oxygen tension and also because of the relatively decreased lymphatic clearance. Now, what about for the lower lobes? due to the